Okay. Good evening and welcome, everyone. We are thrilled to host you at the first ever IVUS NIRS webinar, proudly presented by Veiva Scientific. We are honored to have a panel of interventional cardiology leaders from all over India here with us today, and we extend a warm welcome to everyone. Without any further delay, I request our moderator for the session, respected Dr. D.S. Chadda sir, to kindly take over and guide us through.
Thank you, Gauri. This, I think, is the first webinar we are holding of IVUS NIRS where we have people from across the country. And it's my honor to invite Dr. Balbir, teacher of teachers, to begin his talk. He'll talk about the benefits of IVUS NIRS. Dr. Balbir has been doing IVUS NIRS for quite some time, and it will be nice to learn from his experiences as to what he found useful with this modality.
Right. Thank you, Dr. Chadda. I hope you can hear me.
Yes, you are heard, sir. You are heard well, and your slides are seen. If you can go into presentation mode, sir.
Right.
Continue. Yes. Something gone wrong? It seems to be.
So I believe there's some network issue.
Network issue with Dr. Balbir?
Yeah. Yes, sir. We can't hear him.
No. His slides are also not moving.
Yeah, he got disconnected. Let's wait for a minute.
Yeah,
So maybe
we'll wait for a while. We'll wait for a while. Let him come back. So everybody knows about Dr. Jain. He's a stalwart from Hyderabad. He's very, very well known there for complex PCI work. And today he's going to talk about IVUS NIRS. Can it predict no reflow? Again, Dr.
Are you
Jain
able to
has
see
been.
my slides?
Okay. No, they have not come as yet.
Okay.
Yes, we can see your slides. If you can go on presentation mode.
Okay.
Perfect.
Okay. So thank you, sir. Thank you, Chadda sir. And I've been using IVUS not very often, but I got very good information from this small case. I thought I should share, and this was my feelings. There's nothing more than this. So this is a 74-year-old male who presented with an acute anterior MI within a window period of 1.5 hours and a mild LV dysfunction. He had his two vessel disease, LAD and RCA, and we did a primary PTCS stent to LAD. We used a 3.5 into 37 millimeters drug-eluting stent. and he came for a stage PT stent to RCA. This was a part, this was his right coronary guiding shot, and you can see there's a tight stenosis. We did a femoral approach for this patient, and are you able to see my videos well?
Yes, yes.
Okay. So this is the angio, and this patient was also part of the complete 2 study where we have to do an IVUS, and this is a pre-PCI IVUS.
OCT.
And this is a pre-PCI IVUS, and you can see it's a trimalar in the landing zone there, and the reference vessel diameter is 3.5 millimeters, and the length of the stent we got as 48 millimeters, and the minimal luminal area is 1.86 millimeters. So I just want to Dr. Chadda's comments again. He's an expert in OCT also. So I'm playing it again, sir. Are you finding? I know people who are an expert in OCT. Some of my colleagues in KIMS immediately say, "Oh, there's a calcium there, and there's here, that is there here." So I thought I'm just playing this OCT for the audience also, and for the legends like Dr. Chadda and Dr. Balbis to join. So anything else did you find, sir, in OCT?
So I feel that this OCT kind of apart from identify the reference diameters and the lesion length, also tells you about the morphology. And if you see the runs in the intermediate segments, you can see what I can see is a lot of necrotic core behind, because we can't make out the plaque morphology in those segments. So it appears that those segments are kind of studded with necrotic core,
This
which
is the
could
segment,
be
sir.
of Panja.
This is the segment I've frozen now.
So no, if you can come a little forward again. Come forward. So the vessel morphology is absolutely not well seen. You can see a small calcific plate at around 3 o'clock or so. It's very small, but beyond that, the complete light is getting absorbed. So you're not getting to see the vessel morphology at all. If you can play it further. So it is these segments, the light is getting completely absorbed and you can't see much happening there. Now, it's very difficult to say whether this segment has got lipid pools or just dead cells and extracellular matrix. And if there is calcium in this segment, it is not well ascertained, and it might be a deep calcium, which we'll get to know only upon dilatation of these segments. But I can't see any big superficial calcific plate here in the runs which you are showing. Here you have the normal segments. Here you have a tight stenosis. And as you come proximally, these are segments where it's complete effacement and you see complete light absorption and there's nothing which is reflected back. These are normal segments.
Okay, sir. So, here in this OCT, I also didn't find anything except the landing zone, the length of the stent, and MLA. That's what how I interpreted this OCT image. So, so I just again. So, did you pick up a thin cap fibroma, or did you diagnose vulnerable plaque? That's what my question is.
So I did not pick up any thin cap fibroatheroma here because, but I certainly feel that there is a lot of necrotic core with effacement and complete light. I mean, the OCT does not reveal the morphology or the architecture, which is completely effaced. That means the infrared light is getting completely absorbed, nothing being reflected back. So there is complete resorption of the light. So it means that there is a necrotic core. There is positive remodeling of this vessel with stenosis and a necrotic core which is present in this segment.
So you think that is there in the mid part of RCA or proximal RCA?
Yes. Yeah, I feel it's in the mid part of the RCA.
Okay. So what we did an near IVUS also here.
Okay.
And this is what near IVUS showed.
Okay.
So here, if you see the distal part where the necrotic core is not much,
Yes.
and if you see the proximal part, that MCBLB index is 851.
Yes.
So that was there in proximal RC.
Yes. So this was, if you see the OCT run, it kind of correlates with that.
Yeah.
Because there is, if you see the vessel, you can't see the vessel architecture at all, and the complete segment appears to be effaced. There is complete resorption of the light there.
Yeah. So, in fact, I think even though I'm an experienced, but I'm not that great fan of an OCT. Okay, I do it just as a part of routine too. But people are very good in interpreting ATC, the morphology, the necrotic core, the vulnerable block, everything. So, but I got this information. I thought, okay, you know where to put the stent. You didn't put it in the necrotic core. Anyhow, that length we got in OCT also as 48, and here also we got 51. So what I did, this is they said that activated macrophages in that OCT that suggests of a vulnerable block. At the same place where the activated macrophages there, you can see my LSPB index is 851. They're correlating very well here.
Yes, absolutely.
So, but what I wanted to highlight is if you see the OCT image here, an experienced person can really say that is macrophage. But here, the color coding by near infrared spectroscopy is very obvious. Okay, that you don't need to be trained to about do some 200 to 300 OCTs. But here, if you use near IVUS, the same information is given. So don't land the stent in this area, and you cover this area, which was and angiographically we don't touch this area. So see what happened. So we pre-dilated the balloon with a balloon, and then we used a 50 millimeters Ultimaster regulating stent in the RCA. So see what happened. The patient had, after stenting, the patient had hypotension, the blood pressure dropped, ST elevation, and the pressure picked up once we gave nicorandil and small NORAD support. So this is the no reflow. So that's what they say, that this near IVUS imaging infrared spectroscopy, whenever there's a more than 400, and in this patient it was 800, which can predict a no reflow. So that information, additional information I got. Definitely, whenever in OCT also you have activated macrophages, definitely you guys get a no reflow. And we gave intravenous nicorandil, and patient had a good result. And because of the part of the complete 2, we did again an OCT run here. The stent expansion is 89%, and stent surface area is 5.81. And you can see small block prolapse there also. We just left it there like that, and we didn't want to touch it because we know that where that tissue hanging is there is a vulnerable block area. We didn't want to touch it more, and we got a good stent area. So then this is that OCT of the same block prolapse, which I was telling. I didn't want to do anything because it will harm me more. I have a very good area and I didn't want to do anything. So then we did an OCT of the, because again, this is a part of the complete 2. I have to do OCT of all the 3 vessels, and the patient comes back after 1 month after interval angioplasty of the end STEMI or STEMI. And this is the OCT again here. And here we are not planning to intervene in this left circumflex artery. And here in again this OCT, this image. So anything, sir, you are able to finding interesting in this OCT again?
Okay, okay.
I'm sorry, sir, I'm putting.
No, absolutely. What I'm finding here, Dr. Jain, is that the OCT kind of in these vessels is showing a lot of attenuation of the light. So wherever there is attenuation and the plaque morphology is getting effaced without any significant backscatter, it is suggestive of a remodeled segment with a necrotic core. Now, what constitutes this necrotic core, neither IVUS or OCT can tell you. As you brought out in your previous IVUS NIRS image, NIRS only has the capacity to differentiate the tissues because it specifically picks up lipid in these segments. So there is a lot of attenuation which is seen in this individual's coronaries. Like this is the attenuated segment, completely attenuated segment.
So I didn't find out anything fibroma here, but if you see, this is the same. I think that was a little bad OCT.
This is all attenuated. This is all attenuated segment of the circumflex.
Yeah. So we did near IVUS here again. And you can see again, FCLB index is 842.
This is very interesting.
So we were very, say here, we didn't want to stent this artery because we already had a no reflow there and we didn't want any troubles. And he had anti-MI recently with a mild dysfunction. So, and this is LC-back. So I just wanted to highlight that how nice it is just to pass an IVUS catheter, you get all the information, but it is extra information you get. And if you see in the RCA, when we stented that area, which included high MCLB index, we got a no reflow. And that's what they say, that whenever the MCLB index high, the chance of no reflow is high.
Yep.
And this is again, if you see the TCFA noted in LCX,
Mhm.
and I'm correlating. So again,
Yes.
I'm telling you to see this TCFA to tell, I think it's not an easy for unless you do 200 OCTs, okay? And
Correct.
you are well trained. But if you see near IVUS is 800, and then just make sure you cover it and then come out of it. I just small, I think, to make it easy intervention. That's what I felt.
Yep.
We did an OCT of, because a part of the study of the LED also. And here the stent expansion is 57, but his stent is well opposed, and 5.53 we got in area. I think that was acceptable in an acute MI situation there. So this I just wanted to highlight that how near IVUS can help. In fact, I feel I am more fascinated with, I think I'll use more near IVUS than OCT in my
So,
of my patients.
perfect. So I'll tell you one basic fact, Dr. Jain, is that, and I'll open the case for discussion thereafter. The thing with the OCT is that you need to acquire good images.
Yeah.
If you don't get good images, you will not be able to interpret those images. So your guide catheter coaxiality, the injection at the right time, and the image acquisition, if on a manual mode, has to be done properly. If not done so, you will not get good images. The virtue of IVUS is that you have to just de-air the catheter and put it inside. It'll do rest of its job. Now, having said that, the virtue of IVUS NIRS is that it gives you additional information. Now, with the kind of case which you've shown, you can take the prescription out of the cath lab to the OPD. Now you've seen that this is an individual who's got a lot of LCBIs. He's got a lot of lipids in his coronaries.
Yes.
So we'll have to use statins for a longer period of time, because we really don't know how long the statins have to be given to a given individual. But here, if it's documented objectively that the LCBI scores have been very high in the circumflex also, and the treated RCA also, we can use high dose statin for a long period of time and help him. Now, my final comment is that about the macrophages. All this is said, but the histopathological correlation is not available. And macrophages are basically lipid-laden cells which are there. These are kind of foam cells. So if on magnified images, we get some cells which produce shadow, if there is some amount of shadowing in presence of the infrared light, we mark them as macrophages, thereby suggesting that this is an area which is active, where active atherosclerosis is on, and the disease is still active, and we might have more lipid pools in these segments. Apart from that, they carry no significance. There are a couple of papers which have also refuted the presence of the capability of the machine picking up macrophages.
So what we're planning is, we want to do about 40 cases with near IVUS. And whenever, as you said, take this prescription to the outpatient, and if some of these patients where we have stented LED and we do near IVUS to other vessels, and if the vulnerable block is there, or that MCLV is more than 400, advise him take more powerful PCSK9 inhibitors.
Absolutely. It's
That's what-
entirely up to the practice protocols of a center, affordability of the patient, because there are studies which have clearly demonstrated high dose statins or PCSK9 inhibitors. They are capable of modifying the plaques and reducing the lipid pools. Percentage atheroma volume reduction has been very, very clearly demonstrated.
That's what's shown in Pacman AMI.
Yes. You have yellow study. Yellow was in the stable angina patients with rosuvastatin. Pacman is in AMI patients.
Yeah.
Any other points, Dr. Balbir, if you want to add something to this?
Yeah, so if you look at the OCT image where you were pointing out the macrophages, you could see there was lipid all around. The intima was thick, there was a plaque, and all around you could see attenuation where you were pointing out the macrophages. So OCT itself was suggesting a lot of lipid here. So if you go back to the pointer that you showed on OCT and see this all lipid. So this on OCT also, this is a lipid-rich plaque. And the same place where you saw LCBI all throughout, you had a OCT image. There was one slide which showed a clear OCT image and a NIR image together. This one, yeah. So you clearly see this is all lipid, and this is exactly what your NIR was. So absolutely right that looking at yellow, you can.
No, Dr. Balbi, the issue is, even though we call it lipid, but the right term is attenuated plaque, because you'll have segments which will not have even drop of lipid,
Yeah, right. So question is
It
that
is, yeah.
I'll also show one case and I then put the question. Okay, this is nice. It's very good.
Sir, one thing. So now you have this, what you said in OCT, the findings of attenuate plaque. Will also predict no reflow, like how it must be?
It can. I mean, thin cap fibroatheromas or segments. Now, the hard fact is, if there is lipid, then only you get slow flow or no flow. You don't get it. You don't get slow flow, no flow, because lipid activates the platelets and the coagulation cascade. These are some hard facts from the pathology.
There is another interesting finding in this image. If you see the IVUS, there is a calcium from about 3-4 o'clock to.
So you can see the same in the OCT image between 3 to 6.
So 3 to 6.
Very nicely correlated.
Beautifully correlated, and this is interesting finding. If you see behind the calcium, it's all black, so you know this is calcium. But if you see the yellow behind the calcium, it also tells you will be able to expand it in this direction also.
Yes, absolutely. No, I mean, it was an amazing case, and this is a kind of case which teaches you that there is lots to be done in the coronary segment. Just merely treating the obstructive lesion is not the answer, and that's why physiology has been a failure in ACS. Physiology works in stable angina patient. I mean, FFR did not have the kind of predictive value of events in ACS, because if you treated RCA, you would have easily missed out on circumflex. So non-infarct related artery, even though is not significant now, but this lipid-laden plaque can trouble later. So there's only one tool which tells you about this, and which is NIRS. NIRS can tell you that, okay, these are lipid-laden vessels and you need to do something about it. If there are no more points, Balbi sir, you can share your slides.
Okay, I'll share my screen. Can you see the full screen?
Yes, sir. We can see the full screen. It's gone again. I think he's again locked out. So that was an interesting, very, very interesting case. And it's a hard fact which we need to remember, that only way you can get your prescription right in ACS patients is by getting to know what is there in their vessels.
In fact, whenever you show these findings to the patient that this is MCLV index, and they'll be more convinced to take any of these aggressive lipid lowering drugs.
Absolutely.
They're really convinced.
Absolutely. No, Dr. Jain, you'll agree with me. Our lipid prescriptions are essentially governed by the quantum of work which we have in the OPD. If you are really busy and the patient says that, Dr. Saab, kuch kariye, you say, no, today continue all. You come next visit, we'll modify your prescription. You continue same drugs.
Yes.
And then if you are free, you will say, all right, today is the day. When
let us,
you will
correct.
cry and crave too many medicines. It's a hole in the pocket. You'll say, okay, statin is something which I can really bring down. So from 80 to 40 and 40 to 20, we start doing. But if you see such images on IVUS NIRS, then you are very, very careful. And the patient also gets convinced.
Yes, patient convinced is important.
Patient gets convinced. So what we can do is that, since Balbir sir has again disappeared, there's some problem with this thing. Do we have Kalai Chalvan?
Yes,
Dr. Kalai Chalvan is there?
Yes.
Yeah.
Yes.
Can you please share your slides? We'll start with your presentation.
Yeah, good evening all. Good evening all to all panelists and moderator. And thanks to Viva to give me the opportunity. Can you share my screen from your side, Veiva team. And in the meantime, I will ask Devendra sir. So the NIRS can be a major role in all acute coronary syndrome PCI. What do you think, sir? In the youngster to roll up other using other modality, imaging modality, it is have more role in the current clinical practice in acute coronary syndrome PCI.
So, see, I think imaging plays a very dominant role. And what we are saying is that NIRS is a differentiator between the existing imaging tools. So it has an additional property which can be utilized. So that's what is the message we are trying to give, that all the other imaging tools are talking about the plaque morphology. They are giving you the lesion diameter and length. But this catheter gives you something in addition to that. So we are trying to highlight that it not only picks up lipid, it also optimizes your prescription. Yeah, we can see your
Thank you.
slides. We can
Yes.
see your slides, and you can go to the presentation mode and start the presentation.
Yeah, the slide sharing from the from their side.
Okay.
So I'm going to present very simple cases. We know the imaging
Next
modality.
slide, please. Okay. Introduce the case.
Hello.
Yeah, make
Hello. Yes, sir. So I'm sharing the slide from my end. Whenever you need me to change the
First, you
slide,
go on
just ask.
presentation mode, please,
presentation mode, please.
Yeah.
and be attentive. Go to the next slide.
Yeah, next slide. So my case is a straightforward case, sir. We know the imaging modality more useful for acute coronary syndrome PCI and optimization of left main stenting depth. Then I feel the major role in the case of any stent failure, like in stent restenosis. So my case is straightforward like cases. A 56-year-old male, diabetes, and he had angioplasty to LAD for ACS 2019. And he has codominant system. RCA was mid RCA total occlusion, and LCX in the OM there is a borderline disease at the time. Exactly, he presented with after 6 years. He presented with unstable angina. So we done the angiogram. Next slide, please. This is angiogram. There is a stent in the middle AD. It was 2019 with 3 into 30 millimeter drug-eluting stent, and the last OM there is a disease. Now disease little bit progressed up to 80%, and it's a codominant system. So there is a stent restenosis start in the mid part of the stent, exactly in the proximal end of the stent. There is a stenosis even proximal to the stent also, and the duration of the symptom exactly 2 weeks. And 2 weeks back he had a new onset of angina. They took ECG is normal. After that he went home. They done the again chest pain and repeat the ECG. Some mild T1 was in the chest lead. Troponin is mildly positive, and it is angiogram done outside, referred to here for further management. So we decided to go for image guided angioplasty. Even angiogram, it look like some calcific lesion in the proximal end of the stent, in the proximal to the stent also. But in the shorter duration of history, I want to do exactly where it is happened. What is the exact cause for stent failure? Whether it's a geographical miss in the proximal end, or under expansion, or malposition, or it's only a near endothelial hyperplasia or atherosclerosis. So I done the image. Next slide. So I took the IVUS, but it is not crossed. This is codominant RCA. Next slide. So it's a routine 7 French guiding catheter, routine run through wire to cross the lesion. And I want to do first straightforward directly for IVUS. Next slide. But the IVUS catheter could not able to cross. So next slide. So I took the small millimeter semi-compliant balloon to dilate in the proximal the tight lesion, and this is after pre-dilatation. Then we took the NIRS IVUS catheter. Next slide. So I want to know how to prepare the lesion. Is there any calcium, or either only lipid-rich plaque? Either what is the exact mechanism for instant restenosis, whether it's a neonatal hyperplasia or atherosclerosis. But the entire stent length was good apposition. There is no evidence for stent restenosis in the proximal, even mid and distal part of the stent. Only the proximal end of the stent, there is a plaque. I may expected maybe more calcium in the proximal end of the stent and proximal LAD, but if you see the IVUS catheter, its stent is expansion is good in the mid and distal. At the proximal end of the stent, there is a restenosis, not much calcium. This is a proximal end, yes. And ostium of the LAD was normal, left main also normal. Mild plaque. So, contrary to the angiogram, I feel the less calcium, lot of fibrotic lesion. Even there is a lipid-rich plaque in the proximal end of the stent. So it give me the clue. I have to prepare the lesion with whether it's a cutting balloon or scoring balloon to vigorously prepare. So after seeing the NIRS, I feel that even normal NC balloon or high pressure OPN balloon heal the lesion and we can optimize the stent. Because of even proximal to the stent also there is a plaque. I not decided doing end up with only drug-eluting balloon because there is a lesion. For me, it's look like a geographical miss in the previous 2019 procedure and there is a plaque progression. There is no evidence of neointimal hyperplasia. So this imaging modality give how to prepare my lesion as well as what is the exact cause of stent failure in this case. Next slide, please. So after that, my the angioplasty procedure becomes simple. I took the 3 into 10 millimeter NCOPN balloon to dilate normally up to optimal pressure 15 to 20. It yielded very well. Because of I rule out there is no calcium. I didn't take the scoring balloon or cutting balloon. Next slide. And the reasonable expansion of the proximal end of the stent and even the lesion also. I didn't find any slow flow, no flow after the dilatation. Next slide. So according to the IVUS diameter and everything, we done the mid LAD also there is a stenosis. We dilated and because of long lesion it in the mid LAD, I taken the drug-eluting balloon in the distal and mid part of the LAD. Next slide. After reasonable preparation with 2.5 into 15 millimeter balloon, this is a depth after depth in the distal and mid LAD is reasonable things. Mild dissection, there is no flow limiting dissection. I was happy with not putting stent in the distal and mid part of the LAD. Then we took, next slide. We took 3.5 into 28 millimeter DES. Just from the ostium of the LAD, overlap with 3 millimeter in the previous stent. Expanded very well in the proximal part of the LAD. Next slide. The tight stenosis pattern were expanded very well. Because of the bend in the mid LAD exactly across the septum, I didn't take any higher pressure balloon in the mid LAD. I took 3 millimeter balloon, dilated in the overlapping part. I didn't dilate anything in the distal part of the stent because where there is no stent restenosis, there is no neointimal hyperplasia from the IVUS study. Next slide. So I took again NIRS. After 3.5 into 12 millimeter dilatation, I took NIRS. Next slide. This is a IVUS study after 3.5 into 12 millimeter NC balloon. Starting from the distal end of the previous stent, it expanded very well. There is no malapposition or anything. And slowly pull back. The stent expansion was good. Except in the proximal end of the ostial part of the LAD, there is under expansion. Other area is expansion is good. Apposition also is good. This overall expansion, oval expansion, there is no malapposition. This is a proximal end of the now currently placed stent. There is under expansion. I took 4 into 4 millimeter NC balloon, dilated very well. Next slide. This is a final shot. The expansion of the good, even septal artery is flowing. And the TIMI flow also is good. So in this case, this NIRS IVUS is given exact characteristic of plaque in the proximal end of the stent. How that will give idea how to prepare this stent restenosis in the proximal end, and even apposition after that post-stent dilatation. Thank you. I want the panelists and moderator how we can good differently do this case. Thank you.
I open the case for discussion. My co-panelist can take up that. Any comments, Dr. Balveer? Did you get a chance to see the case? You have to unmute.
I was offline, so I couldn't see the case.
Okay,
Sorry, I couldn't see the case.
No problem, no problem. So this was a case of stent failure, an ISR in the proximal segment, probably related to either a geographical mismatch, which I think is the most probable cause. So the proximal end of the stent developed a neoatherosclerotic plaque. Now, NIRS has the capability of detecting lipid, but it cannot temporally place it, whether it's superficial or deep. So since there was a little ISR segment, so it looks like that there was a lipidic neoatherosclerotic plaque there. And what I didn't understand was your usage of OPNNC balloon for dilating the proximal end of the stent. Why did you specifically choose OPNNC? We normally don't use these balloons, and specifically in segments where we have noticed a soft plaque.
Yes. Actually, usually any stent failure, the chronic instant stenosis, usually we will take cutting balloon, scoring balloon. Here, I could not able to see more calcium, so I could avoid it. Good sir, maybe even normal NC balloon itself in this lesion, it can yield the plaque and the expansion.
Yes,
But I was still in confusion whether it is normal NC balloon will give the proper expansion like that. That's why I put the OPN. But in this case, my case, even normal NC balloon, it gives the good result.
Absolutely, absolutely. I think that is one thing which I would have done differently. And maybe I could have avoided a very long proximal stent, because in the proximal LAD, I didn't find lesion extending so much into the osteoproximal LAD. And I didn't see you preparing the distal LAD bed before putting the drug-coated balloon.
Yeah, I
So,
took initially 2 millimeter, then 2.5 into 15 millimeter NC balloon.
yeah, okay.
So I dilated. I took it's a cutting balloon to dilate without much dissection prior to sepsis.
Okay, since those slides are missing, so that's why I
Yes.
thought, because you presented the NIRS run and then you showed drug-coated balloon for the distal LAD, so that's why I thought probably. No, overall a nice case showing neoatherosclerotic plaque, so which was lipid laden and was managed adequately. Any other comments from anyone in the panel? Will be sir.
I myself, Dr. Arshad.
All right, yeah, Arshad, please.
Yeah. Nice case, and Dr. Kalaichal. And just I want to know what made you to take the NIRS for this case. It's a case of stent failure. What prompted you to take NIRS for this case?
Yeah, because of that shorter duration of the symptom and there is a ECG changes. I want to know, I know that OCT will give the better picture in this case. But I want specifically this NIRS, how it will, whether we give the calcium more or recent lipid rich plaque are rated. Exactly, it give the, it rule out there is no calcium at all. And it's more of lipid fibrotic plaque. In this case, I want to take OCT, but on the day it is NIRS is available in the immediately, so I took. Whether it will guide the how to prepare the lesion.
Arshad, anything specific in your mind when you asked?
No,
So
it
my
was a
answer
case
to
of
this
stent
question is
failure, sir.
okay.
It was a case of stent failure. Probably the etiology and all would have been better detected by an OCT. So that's what. And there's no the previously the stent was implanted in an image guided manner, doctor.
Yeah, yes, 2019 with IVUS guided.
So I think OCT gives you phenomenal surface details, which you are absolutely right. So if there is a new intima, the character of new intima, calcific, lipidic, etc., can be very easily ascertained. But the depth analysis is possible only with IVUS. So if you're looking for stent expansion and if you're looking for the plaque behind the stent, then I mean, you can't match up the details of IVUS. Having said that, both modalities are equally important. We cannot say that stent failure is diagnosed only with OCT and not with IVUS. Both modalities are equally important. One gives the depth analysis, the other one gives you the surface details. And if you're using NIRS, you get in addition the character of the new intima. Right. Any other one? Any other points from anyone else? Or else, I think third time lucky, sir. I think you've changed your laptop.
Yes, I have.
I could make out.
So I hope now it is clear.
Yeah, you've changed the background as well. Imaging Exotica with IVUS.
So,
Wonderful.
so now the question is that what about NIRS IVUS? So my answer to this question is that if I have not used OCT, there is no specific reason to use OCT, I have to use an IVUS. Let's say the creatinine is high, or I have want to give less contrast and I want to get images, or I have guiding which is not hooking well and I will not be able to get good images and I have to do an IVUS. Then I say, okay, I want to do an IVUS. Why not do a NIRS IVUS? Why should you do the other companies IVUS when you're getting more information about the plaque than you get otherwise? So if you have to do an IVUS, we think of doing an IVUS with NIRS. So if I have to do an IVUS, I would prefer this modality because as far as I see, the images of IVUS are almost similar to what I get from the Boston IVUS catheter. So it is almost similar. A little bit of color differences, and I sat down with Gary Mintz on that, and he agreed with me that the image quality is almost the same. So if the image quality is the same at the same cost as the cost of the other catheter of other company, I'm getting information about the lipid core. It adds to my knowledge and to my benefit and to my experience. So that is how I decided to start this NIRS IVUS in our hospital. Now we have done about 500 cases or 400 cases, I don't know. They may know better because we are collating the data. So it's the only FDA approved device to have NIRS and IVUS. And again, Gary was saying that this was brought to him and he said that they had NIRS without IVUS. It started as NIRS without IVUS. And there was no point actually to have NIRS but no IVUS in it. So how does NIRS work? So NIRS catheter emits infrared light, typically in the range of 700 to 250 nanometers into the arterial wall. And this interaction of the infrared light is able to distinguish lipid, collagen, and calcium. Different materials absorb and scatter the light in a different specific wavelength. And this data collected is then put into signals. Signals are put into colors, and that's how we get the signatures of lipid-rich or calcium. So vulnerable plaque is very clear on our autopsy. Beautiful studies by Renu Vermani. Very difficult to tell on an angiogram. For example, this patient, this is the angiogram in the cath lab, and unfortunately didn't make it. But you see how the vulnerable plaque is in this right corner. This cannot be made out by angiography and to some extent by OCT, but not by IVUS by any means. So let's look at this patient, a 71-year-old hypertensive diabetic, triple vessel disease. ejection fraction 25%, inferior wall MI. This is the situation now you have on the left side. The circumflex looked like a CTO, and the LAD was a tight lesion, long lesion. So we chose, because the routine wire didn't go, we chose a Cath second, and this is the microcatheter across this lesion. So this was the first wire, after which the microcatheter was passed down, and a passage was made for the NIRS IVUS to work on it. And this is the NIRS IVUS. So you see the running images of the IVUS. They are absolutely clear. And the good thing I like about this is the touch screen. You can take measurements very easily, very quickly by the touch. So you see that now let's look at the LCPI of this case, 934, and see the areas of yellow. So this is another predictor that you will cross. But there is some calcium on IVUS imaging, but this calcium is very limited to some arcs, but very high plaque rich body. So you see the LCPI at these 2 points that I'm showing you, very high lipid content. Now the question is that we know it's high lipid content. We pre-treated with nicorandil, diltiazem, and nitroglycerin. And after pre-treatment, we stented this lesion, and this is what happens. Very high predictive value. The question comes is that how should we avoid? Should we have avoided a stent and done a DCP in this patient? Because what have we achieved? We knew that this is kind of a very high risk for slow flow, but fortunately, the pharmacotherapy finally worked after 10-15 minutes. Some hypotension happened, but everything settled, and you see this is the LCX pullback. So after the stent, you see the pullback. So this IVUS image is as good as Boston images. There is no doubt in my mind. And as we pull back, you would see we coming back. And we come back towards the left main ostium, the circumflex ostium. And so the pullback speeds can be 0.5, 1, and 2. So it's very slow. We keep it generally at 1. So we are now the left main comes. So we are now reduced the LCBI index from 900 plus to 650 plus. Now this is a good indicator of reduction, but we don't know what percentage of reduction, and is important. So there is a plaque distal to this, the distal part of the lesion. Now this is the LAD. So LAD also had a very severe stenosis and a very high LCBI. And again, this was stented, not much slow flow this time. But post LAD, you see from 646, we reduced to 348, 387. And the circumflex, we reduced from 946, 964 to about 560 or so. So this is a good indicator to tell you that this is a good achievement of reducing this lipid after a stent. But do we actually know how much benefit it does? Will it reduce how much MACE? We don't know. But some predictor is there that this is the good indicator. So this was the final pictures. Patient has done well. His EF improved to 45% on follow-up and did well subsequently. So what is the association between high lipid content and slowed flow? In this study, there was a big association between pre-PCI LCBI index and slow flow. And this association was with p-value of less than 0.1. And we saw this case clearly, and we saw in one more case today showing similar outcomes. So with this ultrasound and NIR going together, we get images simultaneously, we get the arcs simultaneously, we get the chemogram of this whole study. So this bandwidth of using a dual system can give you a big idea. For example, in this patient, you have a calcium arc on the IVUS, and the calcium, behind the calcium, you see no light coming, but you see a yellow signal. This yellow signal behind this calcium tells you that you will be able to expand this calcium also. So if you know about calcific nodules, they could be having a fat behind, or they could be rock behind. So if you have a fat behind a calcium, my thinking is you should be able to expand it much better than if you have calcium behind it. So this also tells you. So this chemogram which we get tells you a lot more than what we think about this. Now we know about vulnerable plaque and plaque ruptures, and this is from Renu Vinani. But are our tools ready for identification of TECFA, even though OCT does tell you about TECFA? But let me tell you, if you ask 3 different operators of a TECFA on an OCT image, 2 may be different from the third one. So it is not a sure shot sign that somebody has measured the TECFA and says this is a thin cap fibroathroма. Yes, you will get the lipid to see. You can measure the intima, but still I'm not 100% sure. You can see plaque rupture, plaque erosion quite clearly on OCT, but TECFA and predicting can be sometimes difficult. So let's look at LRP study. There were 1,500 subjects. 2 vessels were imaged with 2+ imaged with NIRS IVUS, and a 2-year follow-up. So vulnerable plaque was, there was a vulnerable patient and a vulnerable plaque. Vulnerable plaque was when LCPI was more than 400 with a low plaque burden, but vulnerable patient was with high plaque burden. So we can predict MACE based on both patient risk and the plaque risk. For example, if this is one example from the case that we, from this study, you see a case example that there is a lesion with the LCBI more than 400 and the plaque burden less than 70, so 70% less. And this patient was left on follow-up, and he came on follow-up with the tight stenosis. You see the tight stenosis, and this predictor is LCBI to predict this kind of a phenomenon. Then we also know about the Prospect 2 natural history study, which had patients with more than one non-flow limiting lesion, plaque burden more than 65, divided into 2 groups, absorb BVS plus guideline directed medical therapy or guideline medical therapy. So in Prospect 2, if you have a plaque burden more than 70 and LCBI more than 324, this patient has the worst prognosis. If you have more than 70% plaque burden and LCBI less than 324, this is a much better prognosis. And this is irrespective of the fact whether this was stented or not stented. Plaque burden less than 70 and high LCBI again is a higher poor. So something best is have a plaque burden less than 70, LCBI less than 324. So this is from Prospect 2. Another example from an adverse event attributed to an untreated non-culprit lesion. So this is the non-culprit lesion, plaque burden less than 70%. And you see this is high lipid at this point. This is a vulnerable plaque. You see not too much stenosis, and this is many of us just don't even bother to do an FFR or an IVUS examination. If you look at the NIRS, it shows a problem. And this patient on day 1116 comes with a tight stenosis. He had an MLA of 3.8, and most of us would not treat MLA of 3.8 at index day 0, but LCBI of 687 comes back with a tight stenosis after so much time, almost 3 years. And of course, we can, as we was pointing out, we can put them on heavy statin or PCSK9 inhibitors or inclisiran. It will have a good impact. So anything above 400, we know is a predictor of events. What about aggressive lipid statin added, PCSK9 added onto a statin in a high LCBI? How does it behave? This was a presentation at ACC. You see the images on top, a big lipid core with the MLCI of 316. OCT shows some calcium here, but this is clearly thin cap fibroatheroma. You see lipid behind it, whole thing is lipid, and this thin cap. This is non-controversial. The clear thin cap fibroatheroma. Then there is some calcium here at about 4 o'clock, and it is not uncommon to have one plaque, soft plaque on the opposite side of the calcium, as in this case. This patient is put on aggressive lipid, PCSK9 plus statin, back when AMI trial. And you see, after on follow-up, the atheroma percentage is down from 62 to 50. The LCBI has fallen. You can see to 155. And the fibrous thickness, the thin cap fibroathoma is now better. Clear example of a follow-up of a patient who's on high dose of statin. So lipid-rich versus a fibrotic plaque. So we also know from this machine that it gives an arc on which side you have the lipid-rich plaque, and also gives us the fibrosis on the other side. So you know where exactly and what kind of balloon. So if you have a fibrotic plaque and your rotawire is on this side, the calcium is on the other side, you know there could be some trouble. And also if you try to do with a negatively remodeled vessel with a high lipid content, outside there's a high chance of rupture. So all this information is there to take and put into clinical practice. So what about stent edge? So this is a very important factor which can be ignored many a times. So if you have a high LCBI, for example, this is a case example from literature again, you have a high LCBI on this where the stent ended. So this is the reference, proximal reference. So there's a plaque, there is some calcium, but you see the arcs of lipid. So we sometimes do not look carefully at this lipid ending edges, and this clearly is not a good site to end your stent. And this is what happens. On follow-up, the patient has edge restenosis. So the belief that edge restenosis has to happen, will happen, is not correct. How well we place our stents and how well we study the post-optimal results of these stents. So we have different populations showing the clear message that imaging the lipid core is important to understand the future events. Now, beyond that, we can look now at a different, this is the futuristic thing, to develop a calcium core index expert. So you have developed a LCBI. What about a CCBI? And this machine has the capability of doing it. Still not, a software is not entered into it. But it can measure you the calcium score also. So it can measure CCBI, which can guide you to atherectomy. And I think I had discussed this at India Live with the company, and we should be getting this kind of software probably next year. And this will be very interesting to have LCBI and CCBI both. So in summary, how is it different? A dual modality intravascular ultrasound with NIRS, IVUS, bigger imaging range, higher pullback speeds. So I said 0.5, 1, and 2, and we generally use 1, unless the patient is little hemodynamically unstable, and then we put it on 2 and then analyze it. Bidirectional catheter movement, sturdy catheter with good pushability. So advantage is studying the plaque in a good fashion and in a robust manner to give you the final answer. Thank you very much. Sorry for being interrupted twice with my slides.
Thank you. Thank you, sir. That was a very holistic and a lucid presentation. Any points from anyone? The co-panelists? You haven't used this in calcific milieu, sir? You haven't used IVUS NIRS in calcific plaques where it really helps you in selecting the atherectomy tools?
Right. So if I have to use an IVUS, I choose a NIRS IVUS. So we put in the NIRS IVUS. and do the same study. So I said anybody with creatinine 1.2 or more, we using IVUS as the preferred modality. So even if it is a calcific lesion, but as I said, if you see a calcific plaque, if you see a nodule or something, and you see a yellow shadow behind it, my confidence that I will be able to correct this calcium is much higher than if I don't see that.
So what we are doing in our lab is that, and I've sent about 50 odd cases to core lab and they are analyzing it. We use it specifically in the calcific milieu because it helps us choose the atherectomy tools. You do an IVUS NIRS run, and if you find the LCBI scores are high, then we just use NC balloons. We don't even resort to using cutting balloons or this thing. And I have case examples where the calcium looked very tight, and post NIRS run, I just noticed such a big blob of lipid pool behind that. Where the lab, everybody was preparing for a rotablation, we just use NC balloon. So it really helps in selecting the tools. There are certain predictors on the IVUS which tell you that you're dealing with a thick plate calcium. This is based on a very small study which studied about 20 odd patients where they did OCT and manually co-registered the IVUS images. They found that if you find multiple rings of reverberation, then you're dealing with a thick plate calcium. So if we see low LCBI scores and multiple rings of reverberation, then we choose either a orbital or a rota burr for these lesions. But the remaining cases, we just manage with NC or at the most using a scoring or cutting balloon. So I mean, I am using personally in my lab IVUS NIRS catheter I made an algorithm based on which I stratify the calcific lesions uh, on high LCBI and low LCBI score. And those with the low LCBI scores, I have to be ready with atherectomy tools. Those with high LCBI score are treated like a normal vessel. You can use NC balloons and deploy the stents and post dilate them, as you were very nicely pointing out. What is this calcium plate sitting on? On a lipid pool with this or on a hard rock. So I mean, we follow this protocol and I found it very useful. And you get very nice round stents without any D-shaped deformity or under expansion. So we find it very useful in this particular arena.
Yes, sir. I would like to really, I have a couple of cases I'm going to present. They are very similar. And one point I would like to add in this is many a times there is inhibition regarding costs because we are worried that imaging will add to the costs and patients are worried about that. But here by selecting the appropriate calcium modification methodology, we end up saving a lot of costs, which I'll be showing in a couple of cases.
Yep, agreed.
So regarding that, the sir told the lipid-rich plaque, how often you will use drug-eluting balloon for this? Dr. Balbir Singh told to avoid no flow, slow flow, how often we could use DEB in lipid-rich plaque? How it will work if there is a lot of tissue and lipid in the lumen?
There's a question for you, Dr. Balbir. He's asking if you have a lipid-laden plaque, will you be using a drug-coated balloon? Is that the question which you're asking?
Yes.
So, it is very difficult to predict that LCB is high. It's a good predictor of slow flow. But I think you should be guided by other facts that how well I have opened the lesion. But this is a good idea for a study that if you have very high LCBI, use a drug eluting balloon rather than a stent. It's an idea which can be studied, but you cannot give an answer at this point in time. What will happen and to the outcomes if you're doing a DCB versus a stent? Will the slow flow will be less? What are the MACE after that? So unless there is a study behind it, it is very difficult to answer this question. But logically, you are right that slow flow is going to happen with the LCBI being high. You can avoid slow flow by using a drug-coated balloon and a drug-eluting stent. It's a very logical choice, but every individual patient will give you the answer.
But already there's a study planned in Europe, sir, where this high LCBI index or vulnerable plaque, they're just treating with drug-eluting balloon. The study is in the underway, sir.
So the bottom line is
Absolutely. So
that if
there's
you
a
have,
study from China also.
sorry, carry on, Dr.
There's a
Balbi.
study from China also.
Yes.
So there's a study from China happening with ACS and MI. Instead of using a stent, use a drug-eluting coated balloon and see you on follow-up. This is a OCT-based study.
No, sir. This even wherever there's a vulnerable block, they're not putting a stent now and doing a drug-eluting
No,
balloon.
I think the logic behind this, Dr. Jain, is that when you have a lipid-laden plaque, number one, it's a biologically active plaque. That means atherogenesis is in the process, because the final culmination of atherogenesis is by spotty calcium coalescing and forming a calcific plate. So if you have a hardened calcium plate with zero lipid, that means it's a fully evolved atherogenic plaque. So the rationality of using drug-coated balloon is to arrest the atherogenesis at that stage and prevent replication of, stabilizing the neointima, thereby preventing further absorption of this thing. So all biologically active plaques will have high lipid pool, and biologically inactive plaques will have high calcium content. So that I think appears to me to be the reason where DEB can be preferred over this thing. But still, as Dr. Balbir said, a lot of work is to be done, and we need some evidence, even though it appears to be a very good modality, but we don't have evidence to support the same. All right, so can we have the next speaker, Dr. Arshad? He'll present his case. Thank you, Dr. Balbir, for your lovely talk. Unmute yourself. You have to unmute yourself, Arshad.
Hope sir, I hope my slides are in the presentation mode.
Yes. Slides are visible in presentation mode, and you're audible also.
Thank you so much, sir. Definitely, this is a privilege to present before the leaders in intervention cardiology at the moment. Thank you so much, Viva, for this chance. And as I am going to present two cases where the NIRS showed how different two cases were, though they appeared very similar in their presentation and also in the coronary angiography morphology. And also in the IVUS findings, they were looking so similar, but at the same time, how they behaved differently. So my first case is a 75-year-old male who is a case of anterior wall MI. He was in early heart LV failure. He was in Killip class 2. He presented a little late by around more than 6 hours, and CAD angiography revealed a triple vessel disease with an ejection fraction of 45%. And this is his coronary angiography picture, a left dominant system, and LAD is ectatic, and you can see a tram line calcification in the proximal LAD from where the LAD is totally occluded. RCA is a non-dominant or probably a small PDA is coming in, which is very diseased, and the LAD is protected through the retrograde collaterals from the RCA. After a thrombus aspiration and a balloon dilatation with a 2 mm balloon, this was our IVUS NIRS analysis. And coming from the proximal, coming from the distal middle LAD to the proximal segment. In the area of interest, the vessel was around the vessel was having a 360-degree calcium, and the vessel was around 5.4 to 5.8 millimeter size, and the MLA at the lesion was around 1.9 millimeter square, and the max LCBA we achieved is 907, which is pretty high. See the yellow color around the lesion, which is around 360-degree calcium along with a 330-degree arc of lipid pool with an LCBA score of 907. So this is the image which we got. The LCBA score of 907. The vessel is very large. Towards the left main, it was measuring up to 6.2 millimeter. And in the area of interest, it was around 5 millimeter and more than 5.5 millimeter. And the distal reference was almost around 5.526 millimeter. And there's a 360-degree calcium at the point of interest. And there is not much of thrombus as we expect in case of antidevelopment. So we prepared the lesion well. In fact, we have used a undersized with a 4x13 NC apparatus was used because I could have taken an NC balloon also, but we have taken a scoring balloon of 4x13. And this point, we were sure about the point which Welbirsan sir was highlighting, because we really don't want to give a 1:1 dilatation for the fear of no flow, especially in an acute coronary syndrome setup with an LCBA score of around 913, as there are data available where if the LCBA score is more than 710, there is a high chance for no flow with this lipid core. And the break in calcium could be demonstrated after the balloon dilatation, and we got a decent lumen gain with a balloon dilatation, scoring balloon dilatation. 8.2 millimeter square was noted with a lipid core now lowered to 368 with no reflow. We have used we slightly undersized the stent with a 4.5 into 15 balloon, and it was implanted at a slightly higher pressure so that the stent went up to 4.805 with a 20 atmosphere. The stent got expanded well. At this point, in fact, we were really hesitant to give a post-dilatation because of the reason cited above. We thought probably a lipid-rich plaque and a lesion which probably will land up in no flow after the post-dilatation. So we thought we will take a NIRS IVUS again and we'll decide. So this is the final imaging, and which showed a very well deployed drug-eluting stent. There was a middle lesion which was left for medical management with an adequate MLA was there, and the stent was very well opposed with no no under expansion was noted, and not much of malapposition also, and post-stenting max LCBA which was noted as 338. So this is the final picture and the final MSA where we didn't a post dilatation just because of the fact that it has got an LCBA score which has got a very high value. So another patient, it's a 64-year-old male who again presented in failure, but he has an history of index pain which was around 12 hours prior. He presented in heart failure with ejection fraction of 30% and angiography showing a double vessel disease. Again, a similar kind of morphology and a left main and a left dominant system, and a tram-lane calcification could be noticed in the LAD, and where the faint antigrade flow could be noted, and more of a protected system. The LAD territory was looking viable also, but ejection fraction was 30%. RCA was also found to become some kind of collateral to the left system. We again gave a wiring, and following which a balloon dilatation was done, following which an IVUS imaging was done using a IVUS NIRS. And again, this has got a very diffuse lesion, especially in the mid-distal segment. There is a significant myocardial bridge with a plaque burden with around 2.2 millimeters square is the 2.6 millimeter the size of the vessel, and 2.2 millimeters square is the MLA at that point with some plate of calcium at that point. Following which the vessel grow up to 3 millimeter, and beyond which there is a 360-degree calcium was noted with not much of lipids behind, with a max LCB of 245 and MLA of 2 millimeter square after the balloon dilatation, and approximately the vessel was looking around 4.6 millimeter. So this was the image we got, a 360-degree calcium, and at the proximal segment with a vessel which is around 4.6 millimeter proximally and 3.5 millimeter, 3 millimeter in the mid segment, and a 2.6 millimeter distal segment with a plate of calcium in the distalmost LAD, and also a myocardial bridge is there at the distal LAD. So we thought probably a hybrid approach with a drug-coated balloon distally and also a drug-eluting stent in the proximal segment would be of help for this person. And with of course, the LCBA score was very low. Low in the sense it is around 245 only. So not much of lipid core behind the calcified lesion. So we thought, because rather than taking an IVL, we thought we will take an OPN balloon and see, because see the nature of the lesion, and we have taken a 3/10 OPN. We went up to a larger pressure, up to 40 atmosphere, and followed by a 4/13 a, scoring balloon is used in the proximal segment, and at the calcified area, we have used a 3/10 OPN at a higher pressure, went up to 40 or something, and the diameter of the balloon went up to 3.5, 2.5 tall NC balloon for the distal LAD preparation, and which was followed by a 2.5 into 2.5 drug coated balloon. So this is the drug-coated balloon insertion, and the OPN balloon is being inflated at the area of the interest, that is the calcified area. So this is after the preparation of the lesion, and the distal segment is also finely prepared, and the proximal and mid segment is also prepared well. With the broken calcium could be noticed in the proximal segment with a 4.3 millimeter square is the lumen gain, and where we used an OPN NC followed by an NSC apart. We implanted a 3/40 drug-eluting stent in the proximal segment, and which is aggressively post-dilated with a 4/12 NC balloon. And this is the final result which could be achieved. This is the final run of the NIRS. We covered the lesion by deploying a long segment lesion, deploying a drug-coated balloon in the distal segment and a drug-eluting stent in the proximal segment. The good stent position could be noticed, and there is no under-expansion, and no edge dissection also noticed. So this is the final MSA which could be achieved. The MSA was 7.2 millimeter square in the mid LAD and 12.8 millimeter square in the proximal LAD area. And MLA at the drug-coated balloon is also good, with around 4.5 millimeter square was the MLA which could be achieved in the distal LAD with the drug-coated balloon, where there is a myocardial bridge also there. So take-home messages: with the aid of IVUS and NIRS technology, we can identify whether lipids are behind calcium or not, and thereby helps in deciding the best calcium modification strategy. If lipids are more than 180-degree arc behind calcium with max LCBI 4 millimeter greater than 400, we can crack the calcium by using NC or a scoring balloon. But on the other hand, if the lipids are less than 180-degree arc behind the calcium with the max LCBI less than 400, a higher RBP specialist balloon or atherectomy tools should be used to break the calcium. Thank you so much.
Thank you, Arshad. I think you showed two lovely cases. Very well done. The only thing is that in the first case, two things I would have done differently. One is the interpretation of the image. I don't think there was a 360-degree arc of calcium. See, when we see a complete acoustic dropout, that means there are two things which can happen. Either the sound waves are getting reflected back or getting completely absorbed. So in that image, your calcium was segmental and short. It was occupying only segment between 5 to 7 o'clock position. In the rest of the area there was a complete dropout, acoustic dropout, but you didn't see any white reflective surface. So if there is a calcium plate, it will be a very white reflective surface like it was seen in your second case. Second case had a complete concentric rim of calcium, which was absolutely, it's like a white ring. It's, if you have a complete 360-degree ring of a white structure, it is concentric calcium plate. In the first case, there was calcium, but it was not concentric, but it was a soft lipid-laden plaque there. But having said that, very well managed. And the other thing which I do differently from you is that I deploy all my stents at nominal pressures and then use NC balloons of whatever size to blow them up, because I always have this thing in mind. If I go higher up with my stent balloons, I will cause, these are semi-compliant balloons, they will cause edge dissections. And if you develop edge dissection at both the ends, then you need either two stents or you need one long stent. Both the edges will be gone. So deploy them at nominal, use NC balloons
For
to
the
achieve
fear
whatever
of, in
size.
fact, having another balloon dilatation, for the fear of no flow. So I thought probably a
So
high
you
pressure.
still went to 20
20.
atmospheres. The maximum slow flow will happen during balloon dilatation, whether you use the stent balloon and cause edge dissection and produce slow flow, or you use NC balloons later and without edge dissection, you produce slow flow.
Quite well, very well taken.
Otherwise, very well done cases. So we are running a little short of time, so I'll reserve the comments for this thing. Ankit, I'm told, Dr. Ankit has got an emergency case. So I'll change the order. So I'll request Ankit to share the screen and present his case. After that, Dr. Ajay can present. You have to unmute yourself, Ankit.
Good
Yes.
evening, sir. Thank you so much for considering having me before Dr. Ajay. I'll just uh, just a minute, sir. Can you see it?
Yes, we can
Yes.
see. Go to the present. Yeah, perfect.
Yeah.
Perfect.
Good evening, everyone. Thank you so much for having me over here, and it's an honor to be presenting my case in front of you all. So I had this 58-year-old male. So this person was basically a relative, and he was a brother of a very senior physician over here who referred him to me for unstable angina. He was having this mild chest discomfort since the past few days. Absolutely no, there was no comorbidities, non-diabetic, non-hypertensive, and just a very strong family history in the terms that his father had a significant coronary artery disease, and also his uncle had significant coronary artery disease. Apart from that, not on any medications, no comorbidities, just some chest discomfort since the past few days. So we did a stress test first, and the stress test turned out to be positive, and subsequently we went ahead and did a coronary angiography, which was suggestive of this was the angio. Here you can see in the first one that the LED shows a significant disease in the proximal to mid segment just below the D1. The D1 itself is looks like quite a significant vessel with significant around 80 to 95% lesion in the mid segment. The RC is a co-dominant vessel with some disease, but not very significant, and something which I was not very focusing too much on. The circumflex is quite a large vessel, co-dominant with no significant disease. So we just did the angio first, and it was the plasty was not done on the same day. The family wanted to decide something, and after 2-3 days, they wanted to go ahead with the plasty, and that's when we planned this whole procedure beforehand with the IVUS with NIRS. So when we started the plasty, we put two wires, one in the diagonal and one in the LED. I first did the IVUS run of the diagonal. As the diagonal was quite a significant vessel, initially my thought process was definitely to wire both the vessels. And mostly I was going to go ahead with the two stent strategy only because the diagonal itself had quite a significant lesion. So this is the IVUS run from the diagonal first, and here you can see that just a minute, yeah, that the diagonal showed a significant disease, but the LCBI score turned out to be quite high, and which on the graph that they have, it turned quite yellow, literally. Just a minute, sorry. Yeah, in this part, here you can see. So the LCBI index was also quite high. The diagonal had a significant disease. The vessel size was almost 2.5 mm, and hence I had decided that we'll eventually go and stent this vessel as well. Post that, we just I don't know why it's quite an old case, but at that time I just thought since the wire is there, I will just do a pre-dilatation as the lesion was quite significant and it was giving just flow disturbances at that time. So I just took a balloon and I did a pre-dilatation. There was nothing significant post that. And here on the last slide, you can see a check shoot showed a good dilatation of the segment of the diagonal lesion. There's good flow in the LAD. There's no thrombus that you can see anywhere. And then I went ahead and did the IVUS run of the LAD. Now in the middle, you can see the run of the IVUS. It was not a very significantly calcified lesion, as on the angio also there was no calcium that could be seen. I was not expecting this case to be something out of the box or something very complex. But the LCBI index definitely turned out to be quite high. And in this area, you can see it's quite a, yeah, quite significantly here you can see that the fibroatheroma can be seen. There is some specks of calcium, but not very significant, not a very heavily calcified segment, but definitely significant disease. So just this, we finished the run for this IVUS and I was just sitting and analyzing the IVUS at that time when someone pointed out that there is a drop in the pressure. So I thought probably the guide must have sucked in, or probably there was some damping because of the guide. So I just pulled the guide out, and still there was no rise in the pressures. So I thought of just taking a check shoot as to what exactly might have happened. And here you can see on the third slide that the whole LED had closed up. So that was the reason, and patient till now was okay, but I knew that since this has happened, that we need to step up our game because this is going to be a problem now. So we immediately took in a thromboster catheter. We started with multiple runs of thrombosuction. Meanwhile, the patient had a brady arrest. There was an anesthetist standby. So we immediately intubated him. There were multiple runs of CPR which were given, revived. Thrombosuction was going on simultaneously. We received good flow post the thrombosuction, but the patient kept on having brady arrest, and that's when I thought, I don't know whether probably there was a dissection or what, but then I just thought of going ahead and stenting the areas from the ostium onwards. Here you can see the first slide where the patient almost is in arrest, and we're just placing the stent. The CPR was ongoing. I just stopped the CPR during the deployment of the stent. We deployed the stent. Immediately post that, we can see there's a good flow noted in the LED. There's no thrombus per se that you can see in the LED as such, but there is no diagonal. The diagonal has completely gone. My wire is inside, but I can't see any flow in the diagonal. Of course, that was not my concern at that point of time. My concern was to get the flow in the LED, which I achieved. In the epicranial view, there was some over here you can see, sorry. Did a post dilatation with 3 and did a pot with 3.5 in the proximal segment. But there was a segment in the first slide you can see over here. Sorry. Over here. That post the stent, there was some but initially I thought probably it's a spasm, but then I gave all the intracoronary vasodilators and still the lesion did not improve. And then I thought of covering it up with another stent in the mid segment as well. And that's what we did. We put in another stent in the mid segment, did a post dilatation with 2.5 and did a post dilatation with a 3O balloon. This is the post dilatation which is going on. Now, there was good flow achieved in the LED, and there was nothing significant left in the LED, and the patient was quite stable as at this point of time. Of course, he was on inotropic supports and he was on mechanical ventilation, but he was not having any episodes of arrest as such. There was no thrombus noted. So I thought of rewiring the diagonal and try to see if I can get any flow in the diagonal. So here we can see I'm rewiring the diagonal. It did not really feel much of a difficulty while rewiring it. Quite smooth otherwise. And then I just did a small dilatation with a small balloon at the just to open up the struts at the ostium of the diagonal. Post that, I could still not see any flow in the diagonal, and that's when I thought, since I have an IVUS in my hand, why not go ahead and uh, put in an IVUS. But before I could do that, here you can see again the whole LED went off. It just closed off again. There was thrombus inside the LED. Again, the patient had a bradyarrest. There was some thrombus noted in the circumflex ostium as well at this point of time. CPR again started. Again, a thrombosuction was done. Intracoronary adrenaline and all those things were given. Patient was revived. The flow was achieved again. And here you can see the flow is again excellent in the LED. The rate is back. The rhythm is back. The flow in the circumflex is also quite good, but still there is no flow in the diagonal. Now, we don't know why this was happening at that point of time, and that's when I decided to just put in a catheter in the diagonal and IVUS catheter, and decided to just take a run as to what I might find in the diagonal. The LED post IVUS results, post ending results of the LED were quite good, and we went ahead and did a diagonal run of the IVUS. And here you can see the catheter the wire had gone true, false, true. And there was, you can see over here, you can see that the true lumen is actually below. My wire had gone in the false lumen, and that's exactly the reason why I was not able to get any flow despite any balloon dilatation. There was some thrombus noted in the true lumen below as well. Since the patient was quite stable, the LED was looking excellent. There was TIMI3 flow, nothing was there in the circumflex, and there was some faint feeling noted in the diagonal. Given the scenario that had happened, I did not want to further do anything to the diagonal, which might get more thrombus out of there and close the LED again. And that's when I decided to abandon the procedure there and then itself, since I had achieved a good result with the LED, and just put in an IBP, shifted the patient to the ICU, did a close monitoring for 24-48 hours, weaned him off gradually, and we got him out. Went home nicely, walking. There were no complications as such. He recovered with the EF also eventually, and the EF was back to almost 55-60, and there was no RWMA as such. Patient is absolutely fine, doing well, and we repeated at the request of the physician, the brother who was the physician. We did a CT coronary angio. He got it done himself actually. He did a CT coronary angiography which showed excellent flow. There was nothing revealing in that. So what I learned from this case was that so NIRS gave me an answer as to probably what might have happened in this case, as there was a high lipid core, high lipid score, with a very lipid-rich plaque disease over there, both in the diagonal and also in the LED. And probably that is the reason why something, but that it ruptured and gave rise to a thrombus in this scenario. So it was a good tool for identification of the vulnerable plaques in this case. And also, since I had an IVUS, the final run that I took in the diagonal revealed also gave me a picture that I was not in the true lumen, and that's when I abandoned it. Otherwise, probably, I don't know, I might have lingered on and done something more in the diagonal at that time, causing more damage. So IVUS definitely, as much as possible, should be used in all the cases. Given the cost constraints, that is something which is not possible always in our country. But specifically, along with that, if we have NIRS associated with it, it definitely gives us a picture as to what we are dealing with and what complications we should foresee, especially in lipid-rich cases and plaques.
Thank you, Ankit.
Yeah.
We have well exceeded our time limit. So a couple of things which I would like to tell you about the cases. Number one is, it was a nice case with a lot of learning points and you brought them out very nicely. My request is that next time on when you present, don't have cluttered slides. It's
Yeah.
very, very difficult. You put 6 angios in one slide, some 6 or 8 IVUS images in one slide. So all your hard work gets diluted. You can have one proper image in one slide that will convey all the meaning which is required. Nobody has got the time, attention. You've done the case, you are well oriented, you will feel all these slides are important, I must show them.
I agree.
But I feel that it kind of dilutes the message.
I agree.
So that is one. Two, I presume that your ACT was absolutely fine
That's
during
absolutely, yeah.
current, the
Yes, that is
recurrent.
something which that is something which I checked. The first thing
Since
that
you didn't mention in your talk, so I presume that it has to be normal,
Yeah.
and that's how you're going on. So the only thing I would have done differently would have been that I would have chased the diagonal no end. Reason being, that's the only branch in the lateral surface. That's the only branch which is going to cause problems. So we have some SNUH score, which tells us whether this diagonal is significant. And this diagonal was really, really significant, being the solitary branch, being a long branch with diameter close to 2.5 millimeters. And your wire was true, false, true. What was required was a 2.5 millimeter balloon and kind of break it open, and you would have ended up with a tap or with a reverse crush or something. So that's how I would have done differently. Having said that, next time on you get in, because your wiring was very easy, and your IVUS catheter very elegantly demonstrated true, false, true, and a thrombus-laden lesion. So I feel that that is how I would have done differently. Having said that, you managed the case very well and you showed a lot of perseverance. I must salute you for having presence of mind of putting back the IVUS catheter to ascertain the etiology of the sudden shutdown of the vessel. Probably what I think is that diagonal branch was lipid laden, which kind of is an idea. There are only two situations where you have dissections. Either you have a fibrocalcific plaque or you have a very soft plaque. So there was a very soft plaque which kind of ruptured. And when it ruptured, it released so much a lipid that it led to formation of local thrombus. This local thrombus migrated into LAD, which would have received only 28 millimeter stent, but it ended up having 60, 70 millimeters of metal in the LAD. But that was required at that point of time as a life-saving measure, which you are absolutely justified in doing whatever at that point of time. And you not only salvaged, you've also had a follow-up. Patient is doing well. So congratulations to you for nicely managing this case.
Thank you. Thank you so much.
So any other point from any of the co-panelists?
I think you should have, as you said everything, I think there's nothing left to tell because the diagonal is the most important vessel for this patient. It's a huge vessel. And according to all the criteria, the diagonal can't be ignored. But anyhow, the patient is fine, outcome is good.
So the only reason why I left it because already I had 2 episodes of that thrombus coming in, and since the physician was sitting outside, it was on my head as well that I don't want to have any more complications and just send his brother home walking. That was my
Perfect. Perfect. I'll tell you one small point since there are a lot of impressionable minds here apart from the seniors. In our lab, the golden dictum is when we get ACS, you're not dealing with ACS. When you get ACS, the rule of thumb is open the infarct-related artery. If you have any significant branch which is diseased, please take the patient out, let the LV breathe. We get him back on the second or the third day. Then you can mess around. Do whatever you have to do. Now the LV has recovered, the patient is out of woods, and the infarct-related artery is better. The LV is pumping and alive. So the more contrast, the more you finger the vessel, there'll be more shutdowns and more problems. So you have to convince your administrators to count as single procedure when for a given procedure you take the patient out because he's not hemodynamically stable. So we do that very frequently because I absolutely don't justify complex interventions during ACS. Anyone with ACS, we absolutely don't allow complex interventions because, you add to the complexity of the hemodynamic status. He's got pain, his LV is down, you are giving catecholamines, there is a lot of vasospasm in the vessels, there'll be a lot of errors in stent sizing, stent deposition, stent deployment. So it is best to let him recover, get him back after 48 hours, and then fix the vessels.
Absolutely. Absolutely. Thank you so
Having
much.
said that, I invite the last speaker of the day. I'm so sorry, the order was changed. So Ajay, you can share the screen
But
and
I feel, Dr. Chadha Saab, no hospital will allow to do that.
no, that is where your skills come into play, Dr.
And
Jain.
lot of people misutilize this opportunity.
Yeah, that is
That's also
correct.
there.
Yeah, I mean, if you're true to yourself and ethical, I think this really works. This really works. Absolutely agreed. Yes, we can see your slides, Ajay, and we are
Yes.
waiting to hear from you.
Thank you very much, sir. Thank you very much for the opportunity. And my cases are mostly about seeing calcium. Uh, Many times what happens is we cannot see what lies beneath the calcium. And my cases are how IVUS NIRS helps us decide treatment strategy, landing zones, and calcium modification tools. Most of the points, almost all of the points have been discussed earlier. This is just a demonstration of these same points. My first patient is a 64-year-old female, diabetic hypertensive stage 3 CKD, who had had a recent inferior wall MI and was thrombolized. Echocardiogram showing mild LV systolic dysfunction. Angiography was done at the other center, which revealed heavily calcified double vessel coronary artery disease. She was advised a bypass. She came to me for a second opinion. This is how her angiogram looks like. If we look at the RCA or the LAD, we see, especially in the RCA, we see a tram track calcification in the proximal segment as well as at the bifurcation. And in mid LAD, also we see heavily calcified lesion. If we were to go treating this lesion just based on angiography, or maybe even based just on IVUS, our probably knee-jerk response would be we might need rotablation, we might need aggressive calcium modification, we might even have thought of IVL, but that is where all these surprises lie. So thankfully I had a IVUS nurse with me that day, and I'll just take it forward so as to come to the area of interest. What we can see as we pull back from the PLV into the RCA. Now I've just moved the video to the RCA. The lipid core goes on increasing, and we see there is heavy calcium. There is concentrated calcium with dropout, but there are significant reverberations. So probably it is not a thick plate of calcium, and as we come further and further proximal, we see that the yellow goes on increasing, giving me a lipid core burden index of 535. As we know, anything above 400 is significant, and above 400 would also I should not land in that zone. The proximal part also shows calcific segment, and I'll just hold forward for the sake of interest of time. We see probably what is the calcific nodule, and then again there was this plate of calcium in the very proximal segment. Now again, sorry for the busy slide, like you said, sir, but we got a LCBI of 535, and different segments showing significant amount of calcific nodule. If we see the left lower segment, we see that there is a almost concentric ring of calcium in that segment. That's in the proximal to mid segment. So this IVUS run was initially carried out after 2 millimeter pre-dilatation. Then based on that, I decided my strategy to be a 3x15 cutting balloon. And when I carried out, I always believe how imaging should be done. It should be done at least thrice in any case. One should be a pre-run. One is after we have done any calcium modification to see the results of the calcium modification. And third should be the final. That should be the minimum time, minimum number of times we should carry out an imaging in any case. So here in the second run, we can see there are cuts across the calcium. and controlled dissection after plaque modification. Then I proceeded to stent from PLV to mid RCA with a 3 by 48 millimeter DES, mid to proximal with a 3.5 by 33, and post dilated these with a 3 millimeter balloon in the PLV and a 3.5 millimeter NC balloon at high pressure in the RC. And these are the final results that I got. What I got here and which was quite surprising, that the LCBI max came down from 535 to 20. I got a minimum stent area in PLV of 5.4 millimeter square and in RCA of 9 millimeter square. And almost everywhere in all these panels, we can see that it is almost all red. Initially, the huge amount of yellow that we were seeing has disappeared. Of course, there is a question: where does it go? It might have been redistributed. It might have gone downstream. We don't have very clear answers for that. So all in all, I got a very good result in this RCA. This was my RCA final run. Where we can see that the stent is well apposed, well expanded, giving me good stent areas in PLV as well as in RCA. Even in the calcific segment, the stent has expanded well, leading to good apposition, expansion, good landing, and significantly decreased LCBI max from 535 to 20. In that same patient, then I pre-dilated the LAD lesion with a 1.5 into 15 followed by 2.5 into 15 millimeter NC balloon and took a NIRS run. I got a LCBI max score of 260. I did cutting balloon pre-dilatation with 2.5 millimeter balloon. Post-cutting balloon dissection, I was able to see again cuts in the calcium and in this case again, in this final, these were the final angiographic results. Final angiographic result was not too bad. As well as the NIRS IVUS, although the score here, LCBI max score here increased from 260 to 310. But again, this was below 400, which is probably we consider a level of significance. My second case is also a similar lady. She was an 82-year-old fit lady who was about to travel to US for a long term at her son's place. She was having clear symptoms of stable angina, exertional angina, and she wanted to be quite symptom free because she knew there would be a lot of walking involved in the US. Her LV function was normal. Ostial LAD showed 50% stenosis followed by 70% stenosis in proximal to mid segment. Angiographically, it was an ambiguous lesion, so I carried out an FFR, which gave me a value of 0.74, telling me I should probably treat this lesion. Circumflex was non-dominant with 70% stenosis in a significantly sized OM, 80% in a small sized OM. Ramus was a small vessel with a 60% stenosis. RCA did not have significant lesion. I've not kept a lot of angiographic views because it was an eccentric plaque, not visible in all of the views. And coming to the NIRS IVUS run, I'll let it play from about 1 minute because it was a long run. It was the vessel was diffusely diseased almost up to the distal segment, but most of the distal to mid part was not very lipid rich. As we come more towards the mid segment, this is where the yellow starts appearing. And we see that the yellow again starts growing. And in this case, we got LCBI max of 873, which was quite significant. And the lipid core was predominantly concentrated in the proximal to mid segment. Again, there was calcium here, but probably even in this case, I could see some reverberations telling me that I don't need to go hammer and tongs with my balloon dilatation or lesion preparation. The MLA minimum lumen area was 2.3 millimeters square. Also, there was a chunk of calcium at the ostium of the LAD, telling me that I cannot land my stent anywhere in the LAD. I will have to go for a crossover from left main to LAD. The distal reference was 2.5 millimeter. Proximal reference was around 4 millimeter. And what was important is there was a huge lipid burden in the heavy calcific segment. I want you to focus on the lower middle panel, in which we can see there is a circumferential calcium. But what we see is it's complete yellow behind the calcium. So this is where we see what lies beneath the calcium, telling me that I might get away, like sir said, with just a high pressure NC balloon, or at the most a cutting balloon. I don't really need to go for any more devices for this. So likewise, I did pre-dilatation with a 2.5 followed by 3.5 millimeter cutting balloon across the osteoproximal calcium. Did a pre-dilatation with a 3.5 millimeter NC balloon at 18 atmosphere, and then carried out a NIRS IVUS run again. And then coming to the area of interest, what we see here near the 2 minutes is there are clear fractures in the calcium. And this would be the ostial LAD coming into the left. So then I could proceed to stenting. I use a 2.75 into 48 millimeters sized according to the distal vessel, 3.5 into 32 from proximal left main to mid LAD. The left main pot was done with a 5 by 6 millimeter pot balloon. The OM plasty, I did use NIRS IVUS in this one as well, but it was nothing remarkable, and we got a fairly good result in the OM plasty. So what we got in this case is more than 100% expansion throughout the segment, including the overlap of the stents, and LCBI max score came down to 214 from 873. So in two cases, what I saw is the LCBI max does go down with like good bed preparation, good landing zones, good stenting. It's not necessary, it might always, but at least in my limited experience, I've seen two cases in which it has really gone down very well, and also giving me very good expansion, apposition, minimum stent areas, and good landing zones. So here again, we see that most of it is converted to red. And I got minimum stent area in left main of around 15.2 millimeters square, minimum stent area in LAD in the distal LAD of 4.9 millimeters square. Proximal LAD showed almost about 8 millimeters square. I'll skip the third case for the interest of time. So my take-home message would be imaging by NIRS IVUS helps to strategize plaque modification strategy. LCBI less than 400 helps to decide the landing zones. NIRS IVUS run after plaque modification, either by cutting balloon or NC, helps to detect cracks in the calcium, therefore avoiding use of further modification devices like IVL. And that is the point I made earlier as well. And that although we are sometimes worried about the costs, increased costs because of imaging, here actually the imaging has helped us decrease the cost significantly. In any of these cases, it was very easy for me to just go with an intravascular lithotripsy balloon, IVL balloon, which would have increased the cost by around 3.5 lakh rupees. But here, just using the catheter has helped me save costs as well and avoid unnecessary devices. And final NIRS IVUS run helps quantify MSA's expansion, apposition, and if there has been any geographical miss. With that, I end my presentation.
I have one question, Dr. Chadda.
Yeah, please, sir. Please go ahead, Dr.
But this everybody is talking about post-stent reduction of MCLBI. It's not going to change any events or clinical scenarios or anything like that. It's just redistribution of the MCLBI. What do you think? So it's not anything. It doesn't have any clinical implications. What I mean to say.
So there is one study of 200 patients. This is a published study. I can recollect the reference and pass it on. So what they noticed was that residual LCBI of 100 increases the stent failure rate by about 2 times. So what this study looked at was post-stenting, they recorded the LCBI and then followed up these patients and looked at the stent failure rates. So this was a 200 patient study where they concluded that higher the uh, residual LCBI score, more are the chances of stent failure, implying that you're leaving behind a component in the cycle of atherogenesis, which is supposed to be the most active component, which is the lipid. It all starts with lipid deposition, and that leads to recruitment of macrophages, which become foam cells, which rupture, which release chemoattractants, which in turn leads to more cells coming in, necrotic core formation, and then spotty calcium, which coalesces to form a calcific plate, and which kind of they can have two types. If it ruptures into the lumen, it's eruptive nodule, and if it protrudes, it becomes the protrusive nodules. Having said that, there is not much, but one study I have come across of 200 odd patients where they look, but the exact mechanism of reduction, as Ajay was pointing out, is not known, whether it's redistribution, distal embolization. There is absolutely no way whether you can predict what will be the residual score like. You cannot even predict how much it will come down and how much it will stay. So that's very, very difficult. But yes, having said that, if we leave behind high residual the LCBI scores, we need to use high dose statins for longer period of time. That's the only thing which I do with my patients.
Okay.
Also, probably with redistribution, we are probably distributing it over a wider area. And when probably the lipid is concentrated in a particular area, we are living a nidus of restenosis. Although this is just like hypothetically speaking, but yeah.
Yep. Okay. Now, one question which is there in the chat box, which I will take before I end the session, is that there's a lot of buzz about Avigo, and you end up comparing the Avigo platform. So the question which is asked is that how does it match up, or how is it different from the Avigo platform? Now, Avigo is the latest Boston platform, but I have had the opportunity of using it, and I have also interacted with a lot of people on different platforms to see their experiences. So one thought process which really matches up is that Avigo is an advancement in terms of AI incorporation into the system and amalgamation of physiology with imaging. But per se, they have not changed the quality of image which the machine is generating. So there is no significant change in the IVUS image quality. That is one, because the same catheter is being used. Number two is that they have what is called the automated lumen assessment. And during my personal experience, I've found that this ALA, which uses the AI component, in about 70% of the times you have to override it because it's kind of not doing its job the way it is expected to. Now, this is purely my experience. I would like the co-panelists and others who have used it to kind of share their experience. Having said that, I feel what Dr. Balbir was saying, when I interact with Dr. Just the name is slipping out. And the expert in the IVUS world
Dr.
over
Gary Mintz.
Gary Mintz. When I spoke to Gary Mintz, he said probably IVUS NIRS, the Makata system produces the highest quality IVUS images in the world. It says the image quality is unmatched if you are using this, and at times when you're using an N catheter, the images are at par with it. Looks like black and white OCT, and which has been substantiated by a lot of people. I mean, the image quality of this is very, very high grade and very good. So, I mean, if there are others on this platform who've had the opportunity to use the Avigo system, they can substantiate and help me answer the question which is there in the chat box.
I second your opinion, sir.
Thank you, Rashid. So, I mean, it's a good modality of imaging, which gives you additional information as well, which helps you not only, as Ajay pointed out, stratify your tools for plaque modification. It also brings the prescription out from the cath lab to the OPD. It kind of instills the confidence, and the case which Dr. Mehta showed, Ankit showed, it clearly demonstrates that how a simple mistake, and I feel that he moment he dilated the diagonal, it ruptured the lipid pool there, was thrombogenic. It led to thrombus formation, which kind of, it was the biggest diagonal close to the ostium. It embolized, caused slow flow, no flow into the LAD, and that's what resulted in, inappropriate stenting of that vessel. And even though the patient is salvaged, but we have left the patient with a lot of metal. So, I mean, imaging has its power, and here we have imaging with the plaque characterization feature, which just requires de-airing of catheter. That's the beauty of IVUS systems world over. You just de-air the catheter, put it in, and you get good images. I thank you all for patient hearing. If anyone has any comments, you're most welcome. I think we have overstretched because, I mean, the presentations are very, very high quality and very informative. I enjoyed each and every moment. And the first case which Dr. Jain showed was amazing. We had an IVUS OCT combo, the same lesion being characterized. So very, very educative. And thank you each one of you present in this platform for making this evening so knowledgeful. Thank you.
Thank you, sir. Thank you, sir. It was
Thank you.
very nice, educative meeting. I learned a
Right.
lot. Thank you, sir.
Thank you.
Thank you so
Thank
much.
you.
Good night. Sir. Good night.
Okay.
Yes, sir. Good night, sir.
Thank you. Good night. Thank you.
Thanks a lot, everyone.